We're going to discuss the thyroid and parathyroid glands, which are also part of our endocrine system. The concepts here are cellular regulation and also fluid and electrolyte imbalance. So let's talk about the thyroid gland, and it's an endocrine gland located in the anterior portion of the neck, just below the cricoid cartilage. Hopefully, those of you who, when the assessment, had the chance to feel someone's thyroid gland when you were assessing the thyroid. It's two lobes that are positioned on the opposite side of the trachea. They're joined together by a small band tissue called the isthmus, and it gives the gland a butterfly-like shape. So this gland here, the thyroid, it functions to regulate the BMR, which is the basal metabolic rate, and the growth and development of a person. It does this by increasing your body temperature and your oxygen consumption. It also boosts your GI motility. That's why when we say people have a fast metabolism when they can eat a lot and not gain weight, and that's because of the thyroid gland. The thyroid gland is controlled by the hypothalamus and the anterior pituitary gland. And the thyroid has two types of cells, the follicular cells and the parafollicular cells. The follicular cells are the ones that produce the T3 and the T4. And the T3 is a thyroxine, and then the T4 is a triiodothyronine. If we don't have enough of these, then we have a problem with the metabolism rate. So too little of these, and we don't have enough usage of proteins, fats, and proper metabolism. So the manufacture of thyroid hormones, it requires dietary ingestion of protein and iodine, because to make thyroxine, which is T4, you need iodine and then the protein tyrosine to kind of combine together to create the thyroxine. So that's why there is iodine in our salt now, so we won't be having issues with that. Because any iodine deficiency, it can lead to decreased production of T3 and T4, which may lead to a goiter, and we'll talk about that later. T3 and T4, they ultimately increase the metabolism, which increases oxygen utilization and heat production by the body tissues. Most circulating T3 and T4 are bound to the plasma proteins, but a smaller portion circulates as a free hormone that can easily enter the cells and attach to the receptor sites within the cell's nucleus. So when T3 and T4, when they bind to these receptors, it turns on the genes that are important for metabolism, and that's how the metabolism starts going. T3 is a more active thyroid hormone, so following entrance into the cell, T4 is then converted into T3. And several factors can actually impede the conversion from T4 to T3. If a person is stressed, if they're undergoing starvation, if they're having beta blockers, if they have medications like amiodarone, if they're taking corticosteroids, this can impede the process of T4 to T3. And cold temperatures may actually increase this conversion. So that's why I'm now turning off the heater and trying to live in cold temperatures. So hopefully my T4 can turn into T3 and improve my metabolism. The other hormone of the thyroid is calcitonin. And this hormone, its main function is to decrease the blood calcium, so decrease the serum calcium. Blood and serum are interchangeable, by the way. So it does this by reducing bone resorption, also known as breakdown. So to decrease the blood calcium, it's going to release calcitonin, and that's going to signal the body to take some of that calcium and stop keeping it from leaving the bone so that can stay in the bone. That's why I like to call calcitonin calcium in. So when calcitonin is released, the calcium stays in the bone. It also helps by reducing the renal tubular reabsorption of calcium. So it's basically trying to get that calcium out of the blood and then into other areas where either it's going into the bone or going out of the body. So the level of calcium in the blood, it dictates the calcitonin secretion. So low calcium levels, they're going to inhibit the secretion of calcitonin, whereas high calcium levels are going to stimulate the secretion. In addition, pregnancy, a high calcium diet, and increased secretion of gastrin is going to increase calcitonin secretion. So once those thyroid hormones are activated and go into the cells and then start the metabolism going, they're going to start doing this by metabolizing all the proteins, the fats, the carbohydrates. It's going to also increase the production of your red blood cells. And then it's also going to exert chronotropic and ionotropic cardiac effects. So chrono means time, tropic means heart. So it's going to improve how fast the heart is pumping. And then for ionotropic, it's going to, iono means how well you're contracting. So it's going to do a better job to pump the blood and contract. It can also act as an insulin antagonist, which means it reduces the insulin secretion. This means your body is more likely to not absorb sugar, but also not break it down either. So this is why when there's hyperthyroidism, this can lead to weight loss. And increasing the BMR can also affect respiratory rate and drive as well by increasing it. So when there's excessive thyroid secretions of those hormones going on, then this is what we call hyperthyroidism. This is a clinical syndrome results when tissues are exposed to high levels of circulating thyroid hormones. In most cases, hyperthyroidism is due to hyperactivity of the thyroid gland. This common endocrine disorder, it can occur at any age, although most patients are usually diagnosed between the ages of 20 and 40. And it occurs more in women than it does men. The high levels of circulating thyroid hormones, it increases the sympathetic nervous system, the SNS. It increases that activity and also the metabolic rate, causing many of the manifestations that you see here in this picture to the right. It can be acute or chronic depending on the underlying etiology. So the thyroid hormone overstimulation, it occurs and the cardiovascular system is affected by causing increased fight or flight responses, which increase the heart rate, stroke volume, myocardial contractility, and the blood pressure as well. Elevated thyroid hormone levels, they increase the body's metabolic rate. So again, they're going to really metabolize that protein, those fats, carbs, all that energy. They're going to do it at a faster pace, and because of this, although the patient has increased appetite and food intake, the energy needs of the body are going to exceed the supply, and then the patient is going to end up losing weight. So with the high metabolic rate, protein degradation is going to exceed protein synthesis. So that's what happens when your metabolism is increased. And it's also going to reduce the fat stores as well. Sustained hyperthyroidism, it can lead to more chronic nutritional defects. Causes of hyperthyroidism include antiarrhythmic drug medications such as amiodarone, because amiodarone is rich in iodine, and remember that you need iodine and tyrosine to combine to make that thyroxine. So a heavily iodinated compound can develop hyperthyroidism. So no matter what the cause, manifestations of overproduction of thyroid hormones, they're termed as thyrotoxicosis. So that just means that there's the overproduction of thyroid hormones. So you can have thyrotoxicosis with or without hyperthyroidism. So, uh, thyroid toxicosis can be caused by radiation exposure, ingestions of excessive thyroid hormone, thyroiditis. Another example of causes for hyperthyroidism is a Graves' disease. Although the overproduction of thyroid hormones is usually less severe in Graves' disease, but this is an autoimmune disease characterized by abnormal stimulation of the thyroid gland. So the body makes antibodies that bind to the TSH receptor. Remember, TSH is a thyroid stimulating hormone. So it binds to those receptors, and then thyroid stimulating immunoglobulins attach to the thyroid tissue. It causes that gland to enlarge, to become hypertrophy, and then the thyroid hormones become overproduced. So, patients with Graves' disease, they demonstrate key features of thyroid toxicosis. We can also have toxic multinodular goiter, and that's caused by multiple thyroid nodules, and it's usually composed of enlarged thyroid tissue or benign tumors. So those are the causes here. So let's dive a little bit into Graves' disease. Remember that Graves' disease is the autoimmune cause for hyperthyroidism, and it's the most common cause for it too. So the body forms these auto antibodies. So they're specific to the thyroid gland. So they're thyroid stimulating immunoglobulins, and those they attach to the receptor sites on the TSH. And then the thyroid gland starts becoming enlarged, and it starts increasing the production of thyroid hormones T3 and T4. So this causes a large number of the glandular cells, enlarges the gland, and also causes a goiter. So you can see the goiter here in that picture below. So so this results in the overproduction of the thyroid hormone, which is, like we said, it's known as a thyrotoxicosis. So this can be diagnosed with blood levels. Usually, if there's a TSH receptor in the blood, also known as TRAbs, and that can diagnose it. So the signs and symptoms of Graves' disease is going to be all the same for our hypothyroidism general symptoms, but it's also going to have two additional ones. So it's going to have the exophthalmos. This is going to be the abnormal protrusion of the eyes, kind of like those eyeball sockets that are coming out. And it's also going to have a pretibial myxedema. So this is, remember, in the pretibial location in the leg, edema. So it's going to look like dry, waxy swelling of the front surfaces of the lower legs. So here we have another example of exophthalmos, which occurs due to the edema and the extraocular muscles, increased fatty tissues behind the eye, and that's what's causing it to push the eyes forward, giving them that bulging look. This can cause photophobia, so patients will benefit from dark glasses and eye patches. Eyes will usually be dry, so they need eye drops for lubrication. So tell the patients to notify their healthcare provider if they develop any preorbital edema, eye irritation, blurred vision, excessive tearing worsened by exposure to cold. Sometimes they might need some surgical intervention to decompress that orbital. And nursing care considerations include, again, protecting the eye, providing lubricant, raising the head of the bed so that there's less pressure on the eyes. And sometimes, even though the hyperthyroidism is corrected, this symptom does not go away. If there is an exacerbation of hyperthyroidism, then this is what we call a thyroid storm, also known as thyroid crisis. So again, a severe state of hyperthyroidism can be triggered by stress factors such as trauma, infection, TKA, pregnancy. This is an acute and life-threatening condition and can actually lead to seizures and comas with a 25% mortality rate. So this life-threatening exacerbation can occur in patients who are undiagnosed or inadequately treated with a hyperthyroid state, mostly associated with Graves' disease, and this is caused by a heightened response in the catecholamine receptor sites. So it intensifies the sympathetic nervous system effects of the body. So for our symptoms, our clinical manifestations here, um, they're exaggerated in the crisis state that include a fever, cardiovascular changes such as tachycardia, hypertension, which can lead to chest pain and heart failure. It can also cause neurological issues such as restlessness, agitation, confusion, delirium. So if it's not treated, then patients can die from heart failure. Treatment for this includes protecting the airway, so probably become intubated. Drugs that are anti-thyroid, antipyretics, glucocorticoids, propranolol. So beta blockers help control signs and symptoms of the adrenergic tone. They also reduce the oxygen demands. A thionamide is given to block thyroid hormone synthesis. PTU is most effective drug to block the thyroid synthesis. It can be administered orally or rectally. An iodine solution can be given to block thyroid hormone release. And then steroids or iodinated radiocontrast to reduce the conversion of T4 to T3 and to promote vasomotor stability as well. So, and then patients can also have cooling blankets, replace fluids that are lost, and also monitor the patients with cardiac and their vital signs, continual vital signs should be monitored. So when you are assessing your patient for hyperthyroidism, whether it's caused by Graves' disease or any other factor, assess for the vital signs. Their metabolism will be speeding up. So what kind of changes do you anticipate in their vitals if their metabolism is speeding up? So they can have increased heart rate, tachycardia, wide pulse pressure means their systolic will be really high and the diastolic could be really low. They can have their temperature can increase, so they may have heat intolerance, increased sweating. Do they have chest pain, chest palpitations? Do they have visual changes? Remember the exophthalmos. Do they have any changes in their energy levels? That might be something you can ask them for their history. If they had any energy level changes in the past few days, weeks, or months. Do they have an enlarged thyroid goiter? Remember that not all patients with goiters have hyperthyroidism because maybe they have a goiter because there's excessive stimulation of the TSH because there's low levels of T3 and T4. So yeah, sometimes if there's a goiter, then the thyroid function can be hypo, or even normal. If there's a goiter, remember now, do not palpate because there is a chance that if you palpate that goiter, you can stimulate the secretion stimulation of the T3 and T4 being released. So if they have hyperthyroidism, you don't want to palpate to stimulate that release because that could really send them into a thyroid storm, thyroid crisis. A simple way to diagnose is to just look at a before and after picture. You will see a difference. But for hyperthyroidism, you can diagnose them based on their health history, clinical presentation, and blood work results, including their blood work for T3, T4, and TSH. Remember that for Graves' disease, they're usually going to measure the TSH antibodies in the blood. A radioiodine uptake and thyroid scan may be performed to evaluate the size of the thyroid gland, the position, and its function. You can also do an ultrasound of the thyroid gland to determine the size of the thyroid gland and to see if there's any masses or nodules there. So if it's a thyroid problem, like if they're trying to figure out if it's a hypothalamus problem, a pituitary gland problem, or the thyroid gland problem, if there's a if it's a thyroid problem, then you're gonna see a lot of elevated TSH, because that means that the pituitary gland keeps on releasing it. So the the thyroid gland is the one that is not getting those results from the TSH. Like something's going on with the communication. Quickly, I forgot to mention in the last slide that TSH might also be increased due to hyperpituitarism, so it might be the pituitary gland as well. Moving on to non-surgical management for hyperthyroidism, we're going to start with the thionamides. For these medications, these include the PTU, the propylthiouracil, and the tapazole, also known as the thiamide. So these function to inhibit synthesis of the thyroid hormone, and they inhibit the conversion of T4 to T3. So they don't deactivate the circulating thyroid hormones that are already made, or the ones that are probably stored in the thyroid, but they do inhibit the synthesis of those hormones. So if they're already made and they're already in the bloodstream or in the cells, then they don't really affect it. So that's why one thing to consider about these medications is that it does not take an immediate effect, because there are already those circulating activated thyroid hormones running around. So other considerations with these is that you want to take them with meals to decrease any GI distress. You want to monitor your labs so they can titrate these medications. And since we're giving patients these medications that inhibit the synthesis of the thyroid hormone, then we really want to watch out for symptoms of hypothyroidism as well, which we'll talk about later. Iodine is another non-surgical medication management. We usually give the iodine as a short-term therapy before surgery. The function of iodine is to decrease blood flow and reduces production and release of thyroid hormones. So it's that negative feedback loop. So the more iodine we have, the thyroid gland kind of notices that there's a lot of iodine, so it knows that it already has what it needs to make that T3 and T4. So if there's a sudden influx of iodine, then the body's going to think that, okay, we're going to have a lot of T3 and T4, so let's stop making those hormones. So this comes as a potassium iodine solutions. So they inhibit the synthesis and the release of the thyroid hormone. And we'll talk later about how that is given before surgery. Beta blockers, propranolol is an example, Inderol. Beta blockers can be used to help control the adrenergic signs and symptoms, especially in the early stages of treatment, before the antithyroid drugs start taking effect. These drugs block the effects of thyroid hormone on the sympathetic nervous system receptors in the heart, so they decrease myocardial oxygen demands. We can also give radioactive iodine to destroy thyroid cells. This can cause progressive destruction of those cells, and potential reactions to this can include pharyngitis or neck tenderness for a few days. Other complications could be hypothyroidism as well. If all the other non-medical, non-surgical methods did not work for our hyperthyroidism patients, we're going to go ahead and move on to the surgical management. Indications for this includes patients who had failed medication therapy. They have cancer or large goiters. And this surgery can be either a total removal of the thyroid or a thyroid subtotal thyroidectomy. If it's a total removal of the thyroid, then without the thyroid, then there's no thyroid hormones being made, which is going to result in hypothyroidism. So if that's the case, they'll be on Synthroid for the rest of their lives. But if it's a surgery that's subtotal thyroidectomy, then it's going to be a part of the thyroid left behind, which may prevent hypothyroidism. Our goal before surgery is to remember the thyroid is very fragile, so before we even start touching, we want to place it in a euthyroid state where it's normal and it's not hyper or hypo. So one way to do this is to give it antithyroid drugs to suppress the thyroid gland. So iodine, also known as a Lugo solution, is used prior to the OR. And like I mentioned before, this medication helps to stop the thyroid from creating more T3 and T4. And then this also decreases the vascularity of the thyroid. And by decreasing that, it reduces risks of bleeding. So we want to decrease risk for surgery. So we get the thyroid symptoms under control. We prevent tachycardia, dysrhythmias, hypertension, especially if they have a goiter, because we don't want to stimulate any secretions of T3 and T4. Remember, we don't want to massage it if they have a goiter, because we don't want to cause a thyroid storm. I like some storms, but not a thyroid storm. So we give these this medication to decrease the size of the thyroid, to decrease its vasculature, to decrease the chances of hemorrhage, and to reduce the risk of thyroid storm. Once they have the surgery, once they're post-operative, there might be some complications. So you want to monitor the vital signs Q15, or however long your policy stays, but usually Q15 for the first 4 hours until stable, and then Q30. You want to assess, are they in pain? If there was a parathyroid injury, this can cause low serum calcium levels, causing hypocalcemia. What are some signs of hypocalcemia? Tetany, right? That Trousseau's. We might also have a thyroid storm. If they still have part of that thyroid, you want to check for bleeding. Are they hemorrhaging? And if they are, do you notice their vital signs? Are you seeing their blood pressure go down, or their heart rate go up, or their respiration start increasing? This surgery is close to the airways, so there's going to be some inflammation next to the trachea. So are they having trouble breathing? Are they in any respiratory distress? They might have some damage to the laryngeal nerve as well, so that nerve can cause spasms, and if it's causing spasms in the trachea, then it's going to cause difficulty breathing for the patient. It can cause obstruction, causing stridor when you listen to their breath sounds. You can also hear stridor without having to use a stethoscope. So you want to keep an emergent tracheostomy tray equipment at the bedside. You want to check the oxygen levels. All right, let's talk about hypothyroidism. This is the opposite of hyper, where your body is going to have a hypometabolic state where everything is slowing down and everything's decreased. So if you look at that picture here, everything, all those signs and symptoms are what you're going to have. A special thing about this is that you might develop a mixed edema, which is happens when everything slows down. So cellular energy, it starts diminishing. So that means certain metabolites start to build up within these cells. When that happens, the cells, they start forming edema from the water and also mix with the mucus. So this water mucus mix creates edema, so that's why it's called mixed edema. This can happen anywhere in the body, but it's most prevalent in the eyes, in the hands, feet, and between the scapula, so around the shoulder blades. The tongue can also appear enlarged, and there's going to be edema around the laryngeal area. So the patient's voice might sound husky or hoarse, and this can develop really slowly over months to years. Remember how I said that the patient having a goiter might not be because of hyperthyroidism? Well, here you can have a goiter as well. So, low thyroid hormone levels, low T3 and T4. Remember that feedback loop. The anterior pituitary is going to see that T3 and T4 not be made, so it's going to release more TSH in an attempt to trigger the production of those thyroid hormones. So TSH will be produced by the pituitary, bind to the thyroid tissue, and it's going to keep doing this to try to stimulate it, but it's not working. And over time, that's going to cause a goiter and that abnormal enlargement of the thyroid gland. So even though this happens, it doesn't necessarily promote the increase of that thyroid hormone production. So this can be causes for hypothyroidism. Most common, 99% of the diagnosis is due to the autoimmune disease, which is known as Hashimoto's disease. This is a chronic autoimmune disease from thyroiditis. The autoimmune disease destroys the thyroid gland, so that's why you don't have any thyroid hormones being produced. Other causes here is due to surgical removal, radiation of the thyroid tissue, or a medication that suppress the thyroid function, such as anti-thyroid drugs and lithium, or the cardiac medication amiodarone as well. Less commonly, hypothyroidism can be caused by dysfunction of the hypothalamus or the pituitary gland. If it's caused by the hypothalamus, you're going to see decreased secretion of the TRH. And if this happens, then you're going to see decreased secretion of the TSH from the anterior pituitary gland. If there's insufficient stimulation of the thyroid gland by the TSH, it can be either caused by a pituitary disease or a hypothalamic disease. Because if the hypothalamus is not releasing that TRH, then the pituitary gland is not going to release that TSH. But if it's a pituitary problem, maybe it can release the TSH or under release it, and if it's over releasing it, then maybe the thyroid gland is just not picking up, or like in like Hashimoto's disease, where maybe the pituitary gland is releasing it, but then the thyroid gland has autoimmune effects that are destroying the gland and not releasing that T3 and T4. So ways of diagnosis, again, usually your T3 and T4 are going to be low, and but remember, TSH, it can either be high or low. It really depends on the cause. So when a patient has a hypothyroidism, or they just had a complete thyroidectomy, they're going to need some thyroid hormones. So the treatment of choice for hormone replacement is levothyroxine Synthroid. So this is a synthetic form of T4, and it has the same effects as the body's own thyroid hormone. It increases the metabolic rate, which is going to increase your heart rate, your blood pressure, and metabolize a lot faster your fats, proteins, and carbs. So, but there are also some adverse reactions to this medication, because it can potentially become serious when it increases the thyroid hormones. So there's a possible chance for hyperthyroidism. So you want to assess for signs and symptoms of that. You want to be cautious with your elderly patients, especially patients with cardiovascular diseases, with hypertension or diabetes or adrenal insufficiency. And you want to teach the patients that this thyroid replacement is taken for life. Do not discontinue it. Do not change brands. Don't change any dosages without contacting the healthcare provider first. And this medication should really be given in the morning because it causes insomnia. So we don't want to take it at night. It's actually the only medication that I give at 6 a.m. before the other medications at the hospital. And so it's usually given in the morning with an empty stomach. And then iron and calcium supplements and antacids, they decrease the absorption of levothyroxine. So patients shouldn't take this medication within 4 hours of having calcium, iron, or soy. So make sure there's like a 4 hour gap if they had these foods or if they're going to eat these foods. And then lastly, patients should follow up with their healthcare provider to assess the serum thyroid hormone levels, because if we're giving this medication, then we're expecting the hormone thyroid levels to increase, and we want to make sure they're not too high, because otherwise that can cause hyperthyroidism. Hypothyroidism that is not detected and becomes even worse can cause a life-threatening complication called mixed edema coma. So this is a life-threatening emergency that occurs often seen in the older adult, usually women in the winter months when it gets really cold, because it exacerbates the slow metabolism. The patient will exhibit worsening hypothyroidism signs, so they're going to be more hypothermic. Their heart rate is going to be more lower, and because of this, it's not pumping out the blood, so your perfusion will be low. That means that you're going to be hypotensive with low blood pressure. There's going to be hypoventilation. Respirations are going to become more slower, and there can be more chances of a metabolic acidosis. Neurologically, the patient can be in a comatose space because they're already weak and lethargic as it is, so they're just going to be more attended, more stuporous, and they're going to be they can be even in a coma. Treatment for mixed edema coma, it includes intubation, mechanical ventilation, thyroid replacement therapy to bring up the thyroid hormone levels to increase the metabolism of the patient. Also giving fluids, vasopressors, and passive rewarming, maybe like a warming blanket. IV dextrose because the blood sugar might be low. But usually mortality is high even with aggressive treatment. The parathyroid gland, let's talk about it. Parathyroid gland is composed of two pairs of small glands located on the thyroid. So a total of 4 small glands, but in 2 pairs. So that's why it's called parathyroid. It releases the parathyroid hormone called PTH. This is the complete opposite of calcitonin. So whatever you know about calcitonin, it's going to do the opposite. So what does calcitonin do? Calcitonin keeps the calcium in, so it doesn't come out to play in the blood. So if the calcium is in, then PTH will bring the calcium out into the blood. So let's bring that calcium out into the blood, whether it's from the bones, break it down and break it down from the bones and bring it into the blood. If it's in the kidneys, it's going to be released. No, we don't want it to be released. Bring it back into the blood. If it's in the GI tract, if you just ate some calcium, then bring that calcium in from the GI tract and back into the blood. It's going to increase your serum calcium levels. Okay, so remember PTH on the kidneys is going to activate vitamin D to increase that calcium absorption from the intestines, and then and also in the kidneys it reabsorbs that calcium back into the blood. Okay, so like again, everything in the calcium we're gonna bring it back into the blood, whether it's from the intestines, kidneys, or bones. Okay, once that calcium in the serum in the blood it starts increasing, then PTH will stop bringing calcium out and calcitonin will start bringing calcium in. Okay, so parathyroid gland, if it's too high or it's too low, it's going to cause either hypo or hyperparathyroidism. So let's talk about hypo first. Let's talk about hyper. Hyperparathyroidism. So this happens when your PTH is high. Okay, so if your PTH is high, that means you're going to have a lot more calcium coming out to play into the blood. So your serum calcium will be high, so that means that you might have hypercalcemia. And if you have that, then you should know the signs and symptoms by now for hypercalcemia. Causes of this can be a tumor on the parathyroid gland or the thyroid gland, and it can be overstimulated in that TSH, or it can, another that's the only real cause. Otherwise, it's unknown why this happens. So if you have this, if you have a lot of serum coming out into the blood, then you want to fix this by having the serum calcium go in by giving calcitone in. And you can also give phosphates. Why? Because phosphorus is opposite from calcium. So if you increase the phosphate in the diet, then you're going to decrease the calcium. You can also fix this by having surgery and removing that parathyroid gland, or if it's a thyroid gland causing the parathyroid, if there's a tumor pressing on both, and there's surgery. So if there's surgery, we kind of already talked about surgery of the thyroid. So if you have surgery of the parathyroid, they're gonna have to open up in the same area. So there might be some post-op surgery complications that are similar to the thyroid being removed. So we've talked about them. It's gonna be similar. So look back into that slide about the surgical management of the thyroid, and look at that for post-op complications for this. Now, hypoparathyroidism is when your PTH is decreased. If it's decreased, that means there's less serum out to play into the blood, so there's less calcium, and that might cause hypocalcemia. So if hypocalcemia is happening, then remember that you're going to have symptoms of tetany, like your Trousseau sign, those twitches. Cause of this, if you had surgery and you removed your parathyroid gland, then you're not making that PTH, so that could be the reason why you're hypo. So surgery removal is the most common cause. Also low magnesium as well. So to correct this, then you're going to have to give calcium, right? Because you don't have enough calcium. So to correct it, give some magnesium. Usually because magnesium and calcium and potassium are like the plastic crew. Remember, so if there's low magnesium, then calcium is just going to follow. So if you correct magnesium and increase the magnesium, then the calcium should start increasing. Or you can give vitamin D as well.